Dr. Hanna. Is Dr. Saed here? I cannot see him. Okay. Dr. Bassam Akasheh. All right. Dr. Walid Dehmis, I can see you. Can you join us, please? Mohammad Hajjiri is not here, but I think Dr. Abu-Anzeh-Jordan is here from the EP. Is he around? Oh, please join us. Thank you very much. Dr. Ramzi Tabbalat. Ramzi, here you are. Please join us at the podium. Dr. Eyas Almousa, is Eyas here? Well, this session is actually, I think it's going to be a highlight session of this morning. It's about heart transplantation and ventricular assist devices in Jordan, a successful history in need of revival. Allow me 10 seconds to tell you about the story. In 1985, late in the afternoon, while I was making rounds at the Cleveland Clinic, where I was a little boy in training, I was summoned to the chairman of the board of the Cleveland Clinic. A lot of you know who he is, Dr. Floyd Lou. So I was summoned to his office, and I was about to lose consciousness when I was called to his office because I thought I screwed up and most likely I will be kicked out of the program. And to my wonderful surprise, when I went there, he actually summoned me up to tell me, congratulations, Hadi. Dr. Dawood Hananiya in Jordan, he's just performed the first heart transplantation in Jordan. It's history. So with this history, I'd like to give the floor now to my session coordinators, Firas and Hanna. Please take it over. Thank you.
Go ahead, Firas.
Good morning, everyone. Thank you, Dr. Hadi. It's our pleasure to conduct this session with you, along with my session coordinator, Dr. Hanna Makhamreh, and with an esteemed panel of experts. It's my pleasure now to introduce our first speaker who is joining us virtually, Dr. Razi Abu-Anzeh from Queen Alia Heart Institute and King Hussein Medical Center, who's going to talk to us about heart transplantation and mechanical circulatory support in Jordan.
I don't see Razi. Razi?
Yes, I'm there.
Oh, virtual. Okay.
Virtual.
Okay. Hello, Razi.
صباح الخير.
صباح الورد.
Dr. Razi, the microphone is yours.
Okay, thank you very much. بسم الله الرحمن الرحيم. أصحاب المعالي والسعادة والعطوفة، الزملاء والزميلات، الإخوة الحضور. صباح الخير جميعا. بالبداية أول شيء كان بودي إني أكون بيناتكم، بس الظروف اقتضت إني أكون خارج البلاد، فمؤتمر زي هذا على هذا القدر والمستوى طبيا وعالميا مفروض نكون نشارك فيه. فباليوم راح أحكي على راح تكون البرزنتيشن تبعي على 3 محاور. المحور الأول راح نحكي بسرعة على الميكانيكال ديفايسز as long as it is one of the modality of treatment of heart failure. راح نحكي على الهارت ترانسبلانت، وبعدين راح نركز شوي على زي ما حكينا على الهارت ترانسبلانت ان جوردن، الهيستوري تبعها، شو اللي صار بعدين، المعوقات وطرق الحل. خلينا نروح كويكلي على الميكانيكال circulatory supporting device. The mechanical circulatory support is a mechanical pump that sustains systemic and pulmonary circulation over a variable period of time. What are the indications of mechanical supports؟ يعني ايش الظروف اللي ممكن نستعمل فيها mechanical support؟ حالات أول شيء ال end stage heart failure, acute cardiogenic shock. We can use it as a bridge to transplant, as bridge to recovery, as bridge to bridge, and as destination therapy. I'll go through the last 3-4 indications thoroughly. First of all, we use the mechanical supporting device as bridge to transplant. إيش يعني؟ يعني إجانا مريض is candidate for heart transplant. Currently بالوقت اللي إجا فيه ما عندي أنا إمكانية أو ما في دونر للتبرع، فأنا how to maintain this patient until we get a heart for him. We put him on a mechanical devices. طبعا هذول المرضى بيكونوا either they have valvular cardiomyopathy, myocarditis, acute myocardial infarction, congenital heart defects, أو بيكونوا post cardiotomy cardiogenic shock. Those patients, we put them on mechanical device until we manage to get them on to have a heart for them for transplantation. The other indication for mechanical devices is bridge to recovery. يعني المريض بيكون عنده acute insult. We are expecting him to recover, but it needs time. يعني بيكون heart muscle either stunned heart أو خلينا نحكي reversible problem, but he cannot recover at that moment. So we help him with mechanical device until the heart recovers. أمثلة عليها post cardiotomy cardiogenic shock. يعني مريض احنا عملنا له عملية he didn't come off bypass easily لأنه the heart is stunned. We put him on mechanical device like ECMO, VAD by VAD until the heart recovers and can take over the job. Other examples are acute fulminant myocarditis, acute myocardial infarction, graft rejection في حالات heart failure, either primary or acute. في حالات right ventricular failure في مرضى الترانسبلانت أو في المرضى اللي صار عندهم pulmonary embolism. برضو we are expecting them to recover, but they need support until the recovery happens. في حالات التوكسيك cardiomyopathy والpostpartum cardiomyopathy. في bridge to bridge أنا يمكن ما ذكرتها. bridge to bridge يعني مريض إحنا بده الفاد. الآن إحنا دخلنا عليه المريض he cannot tolerate until we manage to get the LVAD, or his condition is not stable to get the LVAD. We might put him on BiVAD, ECMO, until we stabilize the patient. Then we put him on that machine. So it's called bridge to bridge. Now the last thing is the destination therapy. Destination therapy يعني it is the final solution for the patient. Ventricular assisting devices is an indication in the following as a destination therapy. إذا المريض he has class 4 heart failure, or he has left ventricular ejection fraction of less than 25, or if the patient demonstrating functional limitation with a peak oxygen consumption of less than 12, or if we have a patient on high inotropic support and he cannot tolerate weaning of these supports, so we have to put him on mechanical devices. طبعا the patient should be appropriate regarding his body size to support the VAD implantation. So بالنسبة للديستنيشن ثيرابي طبعا احنا عندنا طلع generations كثير. The last ones كان الهارت ميت 2 بعدين اجى الهارت ميت 3 بلشوا يجربوه من 10-15 سنة. They found that destination therapy is currently recommended in those patients who are stable, and the implantation can be performed electively. The 1-year survival until now for the new generations of mechanical device is up to 86%. So it is comparable to the survival rate of heart transplant, and can be alternative for heart transplant in those patients who are not candidate for transplant, and especially the old ages patients. Now, what are the limitations of using the assisting devices? It is sepsis, decreased life expectancy, anatomical limitations, severe psychotic disorder or abuse of alcohol, if the patient is non-compliant, or if he has irreversible organ failure like renal or hepatic failure, or if there is severe coagulation disorders. Regarding the complications of the assisting devices, it's bleeding, air embolism, thromboembolic event, hemolysis, right heart failure, aortic insufficiency, infection, arrhythmias, technical disorders, and psychological disorders. Now, how we select the device? We have many supporting devices, depending on what. First of all, it depends on the anticipated endpoint of treatment. Why we are using this device? Is it for bridge to transplant? Is it for bridge to bridge? Is it bridge to recovery? And we should consider the expected time we need the device. Is it just temporary for a couple of days, for 1 week, or we might need it for 1 month, or more than this? Now, we should consider also the type of ventricular support. Do we need to support the right side of the heart, the left side of the heart, or both ventricles need to be supported? And The other factor is the patient factors, which is body size, habitus, blood type, pre-existing contraindications, and anticoagulation therapy. And the most important is the experience of the surgeon and institute. Are these machines available? Are there surgeons that can deal with these machines? All of these factors should be considered before starting the mechanical support. What are the devices that are used? The most common one, and we all know about it, is the intra-aortic balloon pump. The other one is percutaneous implanted blood pumps like Impella. Our cardiologist colleagues, they know well about it. The ECMO and the VAD. Let's go thoroughly through the VAD. It is a mechanical circulatory device that is partially or completely replace a function of a failing heart. What's the goal of VAD? It is to direct the blood away from the failing ventricle, either the right or the left, and provide a flow to the circulation, either the pulmonary or systemic circulation. Of course, the types of circulatory devices are either pulsatile pumps or continuous flow pumps. First of all, the first successful one was the HeartMate 2. It showed that it improved the survival and quality of life in patients with advanced heart failure who are refractory to medical therapy. But the problem was that it was associated with significant risk of pump thrombosis, requiring pump exchange, limiting long-term durability. And it has also other major drawbacks like stroke, bleeding, and device-related infection. That's why when the HeartMate came over the market, it was like alternative to heart transplant, because first of all, they corrected all the problems that happened in HeartMate 2. So they showed that it improved the survival, it improved the durability, and all the side effects who was in the HeartMate 2 is not there in that new generation. I'm not going through the engineering of this machine. However, I'm going to show you the machine itself. It's one of the operations I associated with when I was in Manchester. This is the HeartMate 3. We tested before the surgery in water to make sure that it's working. Now, after opening of the chest, this is the heart. The index finger is on the apex of the heart where we have to implant the device. And then this is the transesophageal echo, also to guide us to the site of implantation. Here we are fixing the base of the device to the apex of the heart. We puncture the apex at the site of the base, and this is the machine that is to be fixed to the base. This machine, or the pump, is fixed to the base this way, as you can see. As you can see, this is a side graft to be connected to the aorta, and this wire is coming out of the abdominal wall to be connected to the battery outside the body. Here, the side graft, the apex with the machine went to its place, and this graft is to be connected to the aorta. This is how does it look like at the end of the surgery. This is the graft going to the aorta, and this is the wire out of the abdominal wall to the battery. There are a lot to tell about the devices, but just quickly, and let's go to the heart transplant now. The heart transplant is a surgical procedure to replace a damaged or failing heart with a healthy heart from a donor. It is the treatment of choice for patients with advanced heart failure, but unfortunately, despite all the success and improvement, only a small number of patients can benefit from this procedure. They showed that there is major imbalance between the supply and demand, and that's why the mortality on the heart transplant waiting list is high. Now, the heart transplant is reserved for end-stage heart diseases. The indications are systolic heart failure with ejection fraction of less than 35, ischemic heart disease, intractable arrhythmias, hypertrophic cardiomyopathy, cardiac tumors, and congenital heart diseases. The absolute contraindications for heart transplant is when the age is more than 70, if there is fixed pulmonary hypertension, if the peripheral vascular resistance more than 5, or if the transpulmonary gradient more than 15. Those patients cannot have a heart. And also, if the patient has systemic illness that limit the survival, like tumor, extracranial tumors, HIV, rheumatic diseases, or any systemic process with high probability of recurrence, or irreversible renal or hepatic dysfunction. Now, the heart transplant, first of all, starts with work up for the recipient. First of all, the recipient, we have to evaluate him well by doing lab tests, including the routine CBC and chemistry, coagulogram, blood typing, immunoglobulin M, G, and M antibodies against the cytomegalovirus, the herpes, the HIV, and and hepatitis, plus the toxoplasma titer. Then we go for the cardiac investigations, as you know, which include the ECG, echo, right and left heart catheter. Once we do all these things and we make sure that the patient is a good candidate, so we can put him on the list. Now, which donor we can get, or from which donor we can get a heart? First of all, his age should be less than 55. Now, the recommendations is up to 60. We should make sure that the absence of the following: prolonged cardiac arrest, severe hypotension, pre-existing cardiac disease, intractable drug injection. We have to check if the patient has severe chest trauma. We have to rule out septicemia, extracerebral malignancy. We need to check if he has positive serologies for HIV, hepatitis B or C. And of course, we need to make sure that he is not on high inotropic support. This can reflect the performance of the heart. After that, we go and evaluate the donor by taking the history from the family, ECG, chest X-ray, and blood gases, routine blood tests.
دكتور رازي دكتور رازي صوتك شوي بس
أعلى ولا أوطى؟
أعلى لو تعلي لنا شوي.
Okay. Also, we need to do cardiac tests for him, which is echo, pulmonary artery catheter evaluation, and if the patient is more than 45 for the males, more than 50 for the females, and they have 3 risk factors for coronary artery disease, he should undergo left heart catheter to make sure that coronaries are not diseased. Then we go to the process of matching. The most important matching process is ABO compatibility. The good thing in heart transplant is that we don't need to do HLA typing in those patients if they are ABO compatible, unless they are allosensitized previously. Then we should pay attention to the matching of the height. It shouldn't exceed 10%. I mean, we shouldn't give a heart for a patient who is 190 centimeter tall to another patient who is 160 or 170. If there is more than 10% mismatch, because or the other way around, because the heart won't come in the thoracic cavity or in the pericardial cavity, it won't maintain the requirement of his body. We also should avoid transplant from old patient to a younger one, and try to avoid fail to male unless there is no options. The marginal hearts also might be accepted in cases of emergencies. Now, assume that we are going through the process. We have a patient with a brain death. We go and see him and evaluate him. We should pay attention to all the details. We should maintain adequate mean arterial pressure. We have to optimize the preload and afterload for that brain death patient. We have to be meticulous with the fluid balance. We should do tracheobronchial tree toileting, and we have also to maintain the blood sugar, potassium, and temperature homeostasis. After we make sure that the donor is, everything is okay with the donor, we can go for retrieval. This is one of the retrieved heart. After we took the heart out of the body, we put it in the ice, check that everything is okay, and prepare the heart for implantation. Now, regarding the surgical transplant, We have two methods. I'm not going to go through the surgical procedure for them, but we have two, either by cable or by atrial implantation. The outcome of heart transplant is as the following. The operative mortality of 30 days is 5 to 10%, and the 1-year survival is up to 82. The 3-year survival is 74%. So the outcome is very, let's say, very good for those group of patients. This is a quick description of the heart transplant procedure. Now I want to mention a few things about donation and donors. The types of donors are three. Either the living donors, يعني, for example, those living donors, أو خلينا نحكي الناس اللي بتبرعوا بجزء من الكبد أو جزء أو الكلية لأقاربهم، أبنائهم، إخوانهم، هذول living donors. إحنا هاي بنشوف منها كثير الحمد لله بالأردن. طبعا بس مش كل الأورجنز can we can take it as donation. يعني الهارت واللنجز cannot be taken from of course alive persons. The other type is DBD, which is donation from brain death patients. يعني هذول المرضى اللي عندهم brain death اللي بناخذ منهم الأورجنز. They are the best because we can manage the patient and get the best performance of the organs to transplant. The third type اللي هو لجأوا له آخر 15 سنة أو 20 سنة اللي هو DCD, donation from cardiac death patients. يعني المرضى اللي بصير عندهم cardiac death طبعا احنا ممكن يتاخذ بسهولة زي ما بنفكر اللي هو الكبد والكلى البنكرياس، بس الهارت لأنه it is the main issue. Recently صاروا ياخذوا الهارت ويحطوه بالاكس فيفو باي باس ماشين. يعني بتاخذ الهارت بسرعه بنحط على باي باس ماشين to keep the vitality of the heart until it is implanted in the patient. مختصر الدونيشن بدي احكي ملاحظه هاي مهمه انه one person can give life to another 9 persons. So the donation of brain death patient is very vital, very important for up to 9 persons. زي ما احنا شايفين all these organs can be donated من شخص واحد زي الهارت أو الهارت valves, lungs, kidneys, liver, intestine, pancreas, eyes and corneas, skin, bone, femoral and saphenous veins plus the tendons. هذا هو الشيء اللي نشدد عليه أهمية التبرع بالأعضاء وإنه شخص واحد ممكن يعطي كل هاي الأعضاء. الآن خلينا نمشي بسرعة نشوف كيف عملية زراعة القلب مشيت بالعالم. زي ما كنا عارفين أول عملية زراعة قلب انعملت بالعالم عام 1967 في جنوب أفريقيا. But unfortunately it wasn't that successful لأنه ما كان في الاميون suppressions. طبعا all through 70s كانت العمليات كلها غير ناجحة. بلش نجاح عمليات زراعة القلب ببداية الثمانينات مع إدخال الاميون suppressions. زي ما احنا ملاحظين هنا بلشت 1982 187 حالة all over the world. بعدين بالثمانينات والتسعينات صار ينعمل بين 4500 ل 5000 حالة بالسنة. هذا this diagram shows the distribution of heart transplant اللي بالأخضر اللي هي العمليات تنعمل في أمريكا قارة أمريكا.
دكتور رازي.
دكتور حنا.
You are 2 minutes يعني beyond your time.
Okay.
If you want to close, be great so that we can open the discussion with you.
طيب أنا خليني بس أحكي على بسرعة أعطيني بس 3 minutes أحكي عن الأردن بسرعة.
Yes, go ahead.
زي ما حكينا الأول عملية زراعة قلب انعملت في الأردن بال85. كانت الأردن أول بلد في الشرق الأوسط، ثالث بلد بالعالم. خلال من ال 85 لل 97 عمل 14 حالة. بعد ال 97 لل 2015 ولا حالة انعملت. البروجرام رجع لنا بال 2015 عملنا كلينيك ويتنج ليست بروتوكولات تيمات. أول successful heart transplant again عملت بال 2018. The patient is alive and doing well. I saw him last week in my office. بال 2020 عملنا كمان حالة بس للأسف he died 1 month later because of sepsis. كان في عندنا حوالي 15 محاولة لزراعة القلب. للأسف ليش ما نجحوا؟ 10 منهم ديكلاين لانهم كانوا يتاخروا بالاخبار عن مرضى البرين ديث. المريض البرين ديث لازم يتخبر عنه خلال 2 to 5 days بعد البرين ديث، بعد هيك بيدخل في سبتسيميا ومشاكل وما بنقدر ناخذ منه الدونرز. المعوقات الرئيسيه عندنا بالاردن اول شيء شورتج اوف دونرز، ما في ثقافه التبرع. تاخير ديلي ان دايجنوسيس اند ريبورتنج، زي ما حكينا هذا من الاطباء ما بيحكوا لنا عن مرضى البرين ديث وما بيتعاملوا مع مريض البرين ديث، يعني هيز اولموست بصير نيجلكتد مريض البرين ديث، مع انه المفروض يصير في اهتمام تو اوبتمايز ذا اورجان فانكشن حتى يكون صالح للتبرع. ما في تواصل بين القطاعات الطبيه بالاردن وحتى بين الاقسام بالمستشفيات. المشكله الثالثه اللي هي الثقافات المجتمعيه والدينيه عندنا، انه هذا حرام هذا ما بصير، وبعدين حتى زمان الكادولز لسه مش متشجعين وما بعطونا ويتنج ليست. الان الحلول، بدناش نظام الفزعه، بدنا تكون الامور منظمه، يعني يكون في سنتر بالبلد يتعامل مع القطاعات الطبيه في الخدمات في الصحه في البرايفت في الجامعات، ويكون في عنده فيدباك من هاي المستشفيات على مرضى البرين ديث. يكون في عندنا ترانسبلانت تيم كوردينيتور، يكون في عندنا دونر مانجمنت تيم اللي يطلع يشوف مرضى البرين ديث ويقيمهم ار ذي اوكي فور ذا ترانسبلانت او لا، ويعطي الفيدباك. بعدين يصير يتم التواصل مع الفرق اللي بدها تعمل زراعه الاعضاء. فاهم شيء بدي اشدد عليه اللي هو الكوميونيكيشن، الكوردينيشن، اللوكال اورجنايزيشن، هاي الحلول اللي ممكن نحلها لمرضى الترانسبلانت. يكون في عندنا سيستميك ابروتش، الناس تتدرب كيف تتعامل مع مرضى البرين ديث، كيف تتعامل مع اهل المريض البرين ديث. يكون في عندنا ريجستري، يعني المفروض زي خلينا نحكي زي بلاد برا، كل واحد لما يطلع له تامين صحي ينعطى ورقه انك ترغب بالتبرع للاعضاء ولا لا ترغب، حتى يكون في عندنا ريجستري مين اللي بده ومين اللي ما بده. بدنا دعم مجتمعي، بدنا دعم من وزاره الاعلام، وبدنا دعم ديني. بس على شغله الدعم الديني، انا بتذكر كان في عندنا حاله هارت ترانسبلانت ورتبنا كل شيء لها. في اخو المريض حكى مع دائره الافتاء، ما بعرف مين رد عليه مع انه في فتوى، بكل بساطه قال له حرام. فاجى قال بيحكوا لي حرام، ما بدي اتبرع ولا باي شيء. واهم شيء يكون عندنا الرغبه كلياتنا كاطباء كمجتمع ان نمشي في هذا البرنامج. ثانك يو فيري ماتش.
Thank you very much, Dr. Razi, for a very nice presentation on devices and heart transplantation devices that we also lack in Jordan. In your experience, Dr. Razi, I will start with you. In your experience, what is available in Jordan right now for somebody who is New York Heart Class 4, basically, unable to perform the usual activities, and at rest he is symptomatic or she is symptomatic? What do we have here in Jordan?
للاسف السبورت
English, please, Dr. Razi, just because we have our Dr. Ferrari and other visitors from outside. Thank you.
Okay, no problem. The only machines that we have in Jordan is the ECMO, and we can't convert it into LVAD, but they are stationary machines. We are trying now in the process of getting the HeartMate 3, but because of financial issues, there is a slowdown. But we are in the process, hoping we get it soon.
Thank you, Dr. Razi, for this comprehensive presentation. Of course, the session is about reviving a rich history of advanced heart failure in Jordan, because it was indeed among the first 10 countries in the world to do heart transplantation. It's sad that this lasted through the 90s, and in 2025, we do not have a steady program for advanced heart failure and transplantation here. I noticed that you listed some problems, some reasons for not having these therapies here, but in my opinion, you didn't list the most important reason, which is not having actual structured advanced heart failure and transplant programs here. We've always had strong surgical history and strong surgical performance, and the surgeons in Jordan have been among the best in the world throughout. But this is not about doing the surgery. It's about having a comprehensive program that starts and is led by advanced heart failure and transplant cardiology, which until today doesn't exist, although we're hopeful that a couple of our Jordanian colleagues are now available in the country and are building some routes for an advanced heart failure program that could be ultimately the advanced program. But you listed it among the solutions. When you talked about the solutions, you talked about needing more organized heart failure and transplant programs. these programs will represent the core that will talk to the policymakers, will talk to the religious figures, will talk to hospitals, will talk to funding sources to establish the actual program again. I also want to highlight that even if heart transplant is hard to get to because of the organ donation issues, there is probably, in my opinion, no excuse not to have a durable ventricular assist device program in Jordan today. And the cost is no longer a good excuse because there are many expensive things being done in Jordan in the field of cardiovascular medicine and surgery. Our interventionalists and EP cardiologists and surgeons are doing things that cost a lot of money. So doing ventricular assist devices here to save the lives of people who reach to advanced end-stage heart failure is very critical because the only alternative for these patients is death. And this is not acceptable in a country where medical care and cardiovascular care has all this history and all these personal capabilities. So I'm going to take this to our panel here. We have Dr. Walid as a seasoned surgeon. We have Dr. Ramzi, who did a lot of work in the heart failure field and has a couple of centers of excellence in cardiac amyloidosis and hypertrophic cardiomyopathy. And we have Dr. Bassam. So let me just hear quickly from you. What do you think is limiting Jordan from having an advanced heart failure program and assist devices? And let's just move away from the cost, because the shortest answer to this is that Lebanon, a country who is in a much worse political and socio-economic situation, has been doing LVADs for many, many years now. They probably did more than 100 LVADs today. I'm sure they're not in a better situation than Jordan. So Dr. Walid.
Thank you very much. Razi, thank you very much. Very nice presentation. I think the lead has to be taken by an institution. Individualized private care is not the answer. Somewhere like the King Hussein Medical Center, where they have the institution and the support and the backup to do this program. It has to be from a big institution and not a small private hospital in Amman. So I think the lead will have to come from people like you, Dr. Razi, to build a team around you and put the case forward to actually build a program that is available for everybody in Jordan. So my take on this is that it has to be from a big institution such as yours. This is my opinion about it.
I don't think I have much to add to what Walid has said. My experience with centers of excellence is that unless you start working in teams with different specialties, different experiences, it's hard to achieve milestones in care of patients, especially when you're talking about expensive therapies. So you really need a focused group of dedicated cardiologists, cardiovascular surgeons, and other specialties in cardiology like EP to work together, preferably in a big institution, as Walid has said, to get the program started. And once it's started, I think there should be no reason for it not to succeed. And as you said, Firas, cost is a limiting factor, but we do a lot of things in cardiology and other specialties that are even more expensive. So we should not just keep blaming economics and the inability to provide for these therapeutic issues. I think we have to work hard. If we work hard and we work together, I think we'll be able to achieve a successful, sustainable program.
Okay, thank you, Dr. Ramzi. We had patients, Dr. Razi, with end-stage and dilated cardiomyopathy, young patients that have decided to go to India,
Yes.
believe it or not. But unfortunately, the outcome was either they were on the waiting list and they died before, or they had the lack of, as you know, they are on multiple medications following the surgery, and they didn't have the proper care following their transplant. I don't know if any of the audience, Dr. Ferrari, or Dr. Hadi, anybody has a question for Dr. Razi before we end. Dr. Hadi has a question. Go ahead.
Razi, thank you very much, and the panelists, lovely discussion. I just wanted to second and insist on the point. We in Jordan would need one center of excellence to do this. We cannot just have it all over the place. If we focus like what Walid said, on one institution which is capable of providing the assist devices, either as destination therapy or a bridge to heart transplant, and build on that in that one center, we probably can reach somewhere. But if we have a scattered type of planning all over the place, I'm sure that will be destined to failure. Probably Firas agrees with me.
I totally agree. I've been involved in establishing programs for the last 20 years in 3 different environments, in the US, in the Middle East, in more resourceful and less resourceful countries. And you need 4 key elements. You need the place, the center, and I'm sure there are great centers here in all sectors. You need the equipment, which is something that could be expensive, but there are always patients who are willing to pay for these assist devices because they have no other alternative. And like Dr. Hanna said, some of these patients went and paid for these devices outside. I saw the first LVAD patient in Jordan here 10 years ago, and he was a patient who traveled to Lebanon to get this assist device done. There's no reason for him not to have it here if he's able to go pay for it in Lebanon. You need the training, which could be provided, and now there are multiple ways to provide that training. And most importantly, you need the team. The core advanced heart failure and transplant cardiologist, somebody like Dr. Ahmad Turk, who is now trying to build an advanced heart failure program because he has that training and expertise from the US and spent some time becoming specialized in it. You need the nurse coordinators, you need the excellent surgeons, and you need the surrounding supporting cast. Once you have that, these are the people who are going to bring everybody together and build this. The last thing I wanted to say is that when you do a program like this, and I've said this before, this is not just for patients from Jordan. There are no programs like this in northern Iraq, from Baghdad north. There are no programs like this in Syria. There are no programs like this in northern Egypt. There are no programs like this in northern Saudi Arabia. So a lot of patients will come from Yemen, from Libya, from many countries, in addition to Jordanian patients. And this program could have the potential to be a very busy program because of patients who do not have other options to go except to places like Thailand or India or Turkey. So this is a call to everybody to put their heads together and work on building a national committee to establish this program through specific champions and hopefully take it to the next level.
Thank you, Dr. Razi.
Thank you. Just a comment, if you please. I totally agree with you that we need a big center or a big institute to take over this job, for example, Queen Halia Art Institute. But at the same time, we need a center that works on the national level to get or to have an access to make a pool of donors. I mean, there in the Royal Medical Service, I cannot access the private hospitals, I cannot access the university hospitals or the Ministry of Health hospitals. There should be a center that can access all these hospitals, at least for the sake of brain deaf patients. So as I have a pool of donors, so we can do it. We can do them. If we stop only with at the military hospitals, I think they won't be enough to supply us with donors for this program. Thank you.
Thank you very much, Dr. Razi. Excellent. Thank you, everybody.
Thank you all, chairpersons, for joining us in this session. Let's move to the next session unless there is a burning question from the audience if you'd like to.